We are going live in 3, 2, 1. We are live. Matriman, we are live.
Yeah, okay. It's showing 8 participants. Should we wait for some time for the people to join? Okay. I'll give 1 or 2 minutes for people to join in. Yeah, okay. So on behalf of Win India, I cordially invite one and all to this exciting webinar on pediatric nutrition. Poor nutrition is one of the best described causes of poor growth in children with chronic kidney disease. Malnutrition is also associated with worsening uremic symptoms and can lead to protein energy wasting and increased mortality. Conversely, obesity is a worldwide problem that is also increasingly affecting the CKD population. So let's learn how to tackle with these two problems today. We have our two wonderful moderators for this session, Professor Dr. Anita Saxena and Dr. Sukanya Govindan. I consider it my privilege to introduce them to you. Dr. Anita Saxena is professor at the Department of Nephrology, SGPGI Lucknow. She has won many Best Paper Awards and international travel grants. She has many international podium presentations to her credit. She's an editorial board and review committee member of many prestigious organizations such as KDOKI, Journal of Renal Nutrition and Metabolism, and so on. She has been awarded the prestigious Bharat Ratna Dr. APJ Abdul Kalam Excellence Award. She has won many international leadership awards. She has over 100 publications, 5 books, and 13 chapters in the books. She has participated in a number of national and international clinical trials. This is just the tip of the iceberg. I will need a whole day to read out her accomplishments. Win India is glad to have you on board today, ma'am. Our second moderator for tonight is Dr. Sukanya Govindan. She's a consultant pediatric nephrologist at Mehta Multispeciality Hospitals and Global Campus, Chennai. She has won many scientific awards such as Niyamatullah Award, ISN Fellowship Grant, ISN Fellow Poster Award, to name a few. She is a liaison officer for the ISN Sister Renal Center at London. Her areas of interest include early recognition of acute kidney injury, AKI therapeutics, low-cost renal replacement therapy, and nutritional rehabilitation. Thank you, Dr. Sukanya Govindan, for sharing your valuable time with us. Our moderators will now introduce the speakers for tonight's August session.
Thank you, Maitri, for that wonderful introduction, and welcome the speakers and all the audience today. It's my distinct pleasure to be introducing none other than Dr. Apna Iyengar today. She needs no introduction. She's one of the strong women in nephrology globally, and she's recognized very well for her efforts towards mentoring people, education, and specifically for today, she's done more exciting work in the field of nutrition, especially in CKD children, where there's a huge gap in data from India. So I could find no other better person to be speaking today on this topic. Madam is professor in the Department of Pediatric Nephrology at St. John's National Academy of Health Sciences. She's also the current chair of ISN Clinical Research Program. She also is the licensed officer for the ISN Sister Transplant Center, along with the center in Rome. She's also the subject editor of the ISN Academy 2021. She holds various posts in International Society of Nephrology, and she's also editorial member, board member of many prestigious journals, including the Peritoneal Dialysis International, the Indian Journal of Nephrology, and many more such accolades to her credit. So welcome, ma'am, for this webinar. Dr. Saxena, if you could introduce Dr. Swati.
Can I share the screen, please?
Yes.
Good evening, ladies and gentlemen, and it is a pleasure to welcome a budding assistant professor, Dr. Swati Kiran Shiri. She's done DM Pediatric Nephrology from St. John's Medical College in the year 2021. Currently, she's a postdoc fellow at St. John's Medical College, Bangalore, and soon she's going to be joining as assistant professor in the medical college at Mangalore. So this is a pleasure to introduce bright, and as Dr. Iyengar said, that she's the brightest student of their batch. So I welcome Dr. Swati Kiran to this webinar.
First, we'll be having the case presentation from Swati, followed by a talk by Dr. Arpana. So I invite Dr. Swati to go ahead with her presentation.
Good evening to the esteemed faculty and all my colleagues. I take this opportunity to thank the Organizing Committee of Women in Nephrology India and my mentor and professor, Dr. Arpana Iyengar, for granting me this opportunity to present the management of undernutrition in children on chronic dialysis. I will be presenting this with the case discussion of a child which was admitted in our center in St. John's Medical College Hospital. Why is malnutrition an important aspect in children with CKD? It is an independent predictor of mortality in CKD. Protein energy wasting in children with CKD is associated with increased risk of cardiovascular disease, infections, prolonged hospitalization, mortality, and growth retardation. With respect to specific anthropometric parameters, height standard deviation can be compromised in early stages of CKD, independent of the glomerular filtration rate. Around 14% risk of mortality is seen for every 1 standard deviation decrease when height standard deviation falls below -3 standard deviation. With respect to weight, higher mortality has been seen when there is a 5% reduction in the weight standard deviation over a duration of 3 months. With respect to body mass index, there is a U-shaped relation with respect to mortality, which is seen across all the age group, and the highest incidence is seen in the first 5 years of age group at BMI standard deviation below -2 as well as above 2 standard deviation. Obesity is associated with 27% of mortality in children with CKD. Coming to the burden of malnutrition in children with CKD, the CKD cohort showed a median weight of standard deviation at 0.03 z-score and height at -0.55 z-score. 17% had undernutrition and 46% of them had obesity. 39% of them had suboptimal weight gain and 62% of them had low muscle mass by mid-upper arm circumference of less than 5th centile. In our own cohort, 58% had undernutrition, 87% had low middle upper arm circumference, 80% had BMI for height age below 5th centile. Munton et al. Reported a 60% malnutrition in CKD stage 3 and above, with average weight and height standard deviation at -2.7 and -2.3 standard deviation. Overall prevalence of malnutrition was significantly higher in the Indian population as compared to the CKD cohort. Coming to the key players of malnutrition in CKD, children with CKD have a vicious cycle of malnutrition, chronic inflammation, and protein energy wasting in a uremic milieu. The factors that is responsible for malnutrition could be classified into those that are secondary to reduced appetite, secondary to abnormal taste, elevated leptin, TNF-alpha, interleukin-1 and 6, nitrogen-based uremic toxins, and number of medications and preference to water intake. It could be secondary to factors such as vomiting, secondary to GER and delayed gastric emptying in CKD, tubular disorders causing obligatory salt and water loss, recurrent episodes of infection. It could be related to dialysis secondary to nutrient losses into the dialysate, dialysis-related inflammation, recurrent infections, hypermetabolic state, and loss of residual kidney function. Apart from these factors, an increase in energy expenditure secondary to chronic inflammation, altered adiponectin and resistant levels, secondary insulin resistance also contributes to this vicious cycle of malnutrition, inflammation, and protein energy wasting. This results in altered biochemical parameters, severe wasting and loss of muscle fat and mass, growth failure, cardiovascular complication, and an increased mortality, prolonged hospitalization, and poor quality of life. With this background, I would like to present the case of baby Anvita, who is aged 1 year, 3 months, is admitted in our center who had recurrent admissions over a period of 1 year. I will be focusing only on the aspect of growth and nutrition in this child. She presented with the chief complaints of history of having failure to gain weight and height over the duration of 1 year and history of recurrent episodes of seizures since 1 day. To summarize, she was a stage 5 CKD who was initiated on maintenance CAPD after admission to our center. Going through her brief history, she's a 1 year, 3 month old child with history of failure to gain weight and height noticed since 1 year. She was not evaluated and treated for the same. She was told to have abnormal kidney function from an outside hospital 1 month prior to our hospital admission. She presented to emergency with seizures requiring ICU admission. There was no prior history of edema, oliguria, or gross hematuria. She did not have any preceding episodes suggestive of polyuria and polydipsia, no progressive bony deformities, no prior requirement of blood transfusion or chronic medication intake. She was a second child to a non-consanguineously married couple with birth weight of 3 kg, and she had appropriate developmental milestones till 1 year of age. Going through her brief nutritional assessment at admission prior to her sickness event, her expected calorie had a deficit of 47.8%, protein deficit of 37.5%, and she was on a mixed veg diet with predominant milk intake, semi-solid kind of a diet, and she had recurrent episodes of vomiting for around 2 to 3 episodes per day, lasting for 1 month prior to the admission. Her anthropometric assessment at admission showed a weight of 7 kg below minus 2.5 standard deviation. Her length was 67 centimeter below minus 3 standard deviation. Her BMI for height age was 12.5 kg per meter square, again below minus 3 standard deviation. Her mid-upper arm circumference was 9 centimeter below minus 2.5 standard deviation, and her head circumference was preserved. At the end of this anthropometric assessment, I would like to open a question for the audience poll. What would be the appropriate growth chart to plot anthropometry in baby Anvita? Option A, WHO. Option B, CDC. Option C, IAP growth chart. Option D, specific syndromic chart.
Shall we end?
I'll just read out the results. It says WHO 25%, IAP chart 56%, syndromic charts 19%. So IAP chart is maximum 56%.
So unlike the maximum that has been quoted as IAP, the answer is wrong. The correct answer would be WHO growth chart. So why exactly it is WHO growth chart, we will see in the later slides. Coming to the interpretation of growth charts on baby Anvita, the weight for age chart showed a standard deviation between -2 to -3 standard deviation. The length for age was below -3 standard deviation. Her BMI for height age was between -2 to -3 standard deviation. So what does the guideline recommend regarding the anthropometric assessment and growth chart interpretation in children with CKD? So the KDOK 2009 and the Pediatric Renal Nutrition Task Force recommendation of 2020 recommends the following anthropometric parameters: length or height for age percentile, length or height velocity, estimating weight for age, BMI for age and height, and head circumference for age. The intervals at which these parameters have to be assessed has also been recommended. In children with CKD on dialysis age 1 to 3 years, at least monthly assessment of these anthropometric parameter and a frequent assessment of weight for age to estimate the dry weight becomes important. With respect to growth chart, the two important growth chart that has been mentioned in the guidelines is WHO growth chart and CDC growth chart. In the initial 2 years of age, the WHO growth chart is recommended because these growth charts have been derived in ideal conditions of mothers belonging to high socioeconomic status who are devoid of habits like smoking and alcohol. They have breastfed their infants at least till 4 months of age, and these infants have been immunized appropriately up to 1 year of age. And they are from a broad ethnic age group, and one of the ethnic group that is included among the 6 countries is India. After 2 years of age, there is no much difference between the WHO and the CDC growth chart. So here on the right-hand side, this is a WHO growth chart. This is the length for age for boys. The charts could be obtained in terms of percentiles as well as standard deviation. This shows the CDC growth chart for weight for age and height for age. Continuing with baby Anvita's examination at first visit, she had mild pallor. She had signs of micronutrient deficiency with angular cheilitis and bald tongue. There was generalized wasting. She also had signs of congestive cardiac failure in terms of elevated GVP, tender hepatomegaly, gallop rhythm, and basal crepitations. Her initial investigations showed a hemoglobin of 8.6 with microcytic hypochromic picture with an iron deplete status. Her urea was 211 and creatinine was 4.6. She was hyperkalemic. She had metabolic acidosis. Her serum albumin was 2.8. She had hypocalcemia and hypophosphatemia, and her PTH was appropriately elevated as per her stage of CKD, and vitamin D was sufficient. We managed her in terms of immediate management in ICU, where she required invasive ventilation for 12 hours. She was stage 2 symptomatic hypertension, which was treated with IV SNP infusion, followed by titration of oral antihypertensive. She was immediately initiated on kidney replacement therapy in terms of peritoneal dialysis with CAPD double cuff 10 cuff catheter of 31 centimeter. Her PD was started with 1.5% one bag and optimized to a 12 hours duration of PD during the hospital stay with 6 cycles of 2 hours and 3 hours duration. Her residual kidney function was 300 ml during the stay of hospital at first admission. Her nutrition aspect, as per the recommended guidelines, her calorie intake was 800 kilocalories that was recommended, protein intake of 8 grams per day. Her diet was advised in terms of mixed diet with egg as a reference protein. Phosphorus was restricted as per the recommended dietary allowance. Potassium was restricted as per the RDA, and she was also started on micronutrient supplementation. Coming to, after the management, to the second question for the audience poll, what would be the expected calorie and protein requirement based on the suggested dietary intake of the Pediatric Renal Nutrition Task Force guidelines? A, 50 to 60 kilocal per kg per day and a protein intake of 0.4 to 0.8 gram per kg per day. B, 65 to 70 kilocal per kg per day with a protein intake of 0.5 to 0.9 gram per kg per day. C, calorie of 72 to 120 kilocal per kg per day and a protein intake of 0.9 to 1.14 gram per kg per day. Or D, 80 to 150 kilocal per kg per day and a protein intake of 0.5 to 0.8 gram per kg per day.
I think we'll end the poll. Majority 56% says 72 to 120 kilocalories per kg per day and 0.9 to 1.14 grams per kg per day. 31% says 65 to 70 kilocalories per kg per day and 0.5 to 0.9 grams per kg per day. And 6% each says 50 to 60 kilocalories per kg per day and 0.4 to 0.8 grams, and 80 to 150 kilocalories and 0.5 to 0.8 grams.
So the audience is right. It is 72 to 120 kilocal per kg per day of energy and 0.9 to 1.14 gram per kg per day. Her other management in terms of other measures of anemia, which was managed with oral iron followed by EPO at follow-up. Mineral bone disease was managed with oral calcium as supplement and binder. She required single antihypertensive after treating her fluid overload with aggressive dialysis. Metabolic acidosis was managed with oral sodamine supplementation for a short duration, and her immunization was up to date along with optional vaccines. So coming to the guidelines again, what does the guideline recommend regarding the energy requirement in chronic kidney disease? So the Pediatric Renal Nutrition Task Force recommends appropriate initial prescription of energy, which is similar to that of healthy children of same age. In those with suboptimal weight gain and suboptimal linear growth, the energy intake has to be adjusted towards a higher end of the dietary intake. In overweight and obesity, the energy intake can be adjusted with respect to appropriate weight gain. However, the nutrition should not be compromised. An additional energy intake from peritoneal dialysis accounts for 10 to 15 kilocal per kg per day. That has to be counted as well. How frequently this assessment has to be done? In less than 1 year, on dialysis at least for every 8 weeks. In 1 to 3 years, at least every 3 months. And in more than 3 years, at least every 4 months. Regarding the protein requirement, again, the Pediatric Renal Nutrition Task Force recommends that the target protein intake in children with CKD stage 2 to 5D should be maintained at upper end of the suggested dietary intake to promote optimal growth. It should not be reduced below the lower end. In children on dialysis, higher requirement of protein intake is present because of the dialysate protein losses. In those with persistently high blood urea level, after having excluded other causes, protein intake could be adjusted towards the lower end of the suggested dietary intake. The dialysate protein losses that has to be accommodated in case of hemodialysis is 0.1 gram per kg per day. In case of PD, 0.15 to 0.3 gram per kg per day. Apart from the protein intake, the type of protein also becomes important. The protein, there is a linear association between the protein and phosphorus intake. And as we all know, hyperphosphatemia is a powerful independent predictor of mortality in children on dialysis. So here in this table, if we look at the protein phosphorus content of various food items, the animal protein overall has a low protein, the phosphorus to protein ratio, averaging around 7 to 11 milligram per gram of protein. Whereas a plant protein has a higher phosphorus to protein ratio, averaging around 20 to 22 milligram of phosphorus per gram of protein. Although the protein content, the protein phosphorus ratio is lower in the animal protein, the digestibility and bioavailability of the phosphorus is much higher in the animal protein when compared to the plant protein. Hence, when choosing the type of protein, it is very important to keep in mind the phosphorus content and the phosphorus to protein ratio. The expected dietary intake based upon the kilocal per kg per day, the suggested dietary intake for various age groups has been given in the recommendations. In case of 1 year of age, the recommended SDI is 72 to 120 kilocal per kg per day, and protein is 0.9 to 1.14 gram per kg per day. Also, in terms of calcium and phosphorus, the chart recommends here the SDI for calcium and phosphorus. In case of 1 to 3 years, the calcium intake should be targeted between 450 to 700 milligrams per day, and phosphorus intake of 250 to 500 milligram per day. And also in case of infants who are on dialysis, it is important to supplement multivitamin, both water soluble as well as fat soluble vitamin based upon the recommendation chart, as well as the trace elements and minerals has to be supplemented. Coming to the nutritional prescription in CKD, what are the options that is available? So the CKD cohort noted that children with CKD consume more sodium, higher phosphorus content, and high protein and calorie intake than recommended. The various options as per the recommendations in managing nutrition in children with CKD is, for infants, breastfeeding is a preferred method. If not possible, whey-dominant formula feed can be used. When prescribed, fluid restriction is present, fortifying breast milk or infant formula becomes important to make it more energy and nutrient dense. The concentration of the feed and adding the supplements in the feed has to be prescribed in a gradual manner to maximize the acceptance and to increase the tolerance. The mode of the feed intake could be solid food, oral food, or enteral feeds. The macronutrient content, specifically the carbohydrate content, should be around 45 to 65%, fat content of 30 to 40%, and protein content of 5 to 20%. The lipid content again depends upon the LDL cholesterol levels. If it is more than 100 milligram per liter, the dietary fat has to be restricted to less than 35%. The fiber intake in those above 1 year of age should be around 14 grams for each 1000 kilocalorie of energy per day. The source being fruit, vegetables, legumes, and whole grains. Regarding the salt and water, the prescription depends upon the native kidney disease and the residual kidney function. In tubular disorders with obligatory salt and water wasting, it is important to supplement the salt and water for optimal growth. In children on chronic PD who have a high ultrafiltration rate, also are prone for the salt losses, and this has to be kept in mind while prescribing the salt intake in children. On the other hand, children with CKD with stage 2 hypertension, sodium restriction has to be done, along with fluid restriction based upon their residual kidney function. The upper limit of salt intake for age group of 1 to 3 years is around 1500 milligrams per day. Again, on dialysis, what are the other options of nutritional management? The first would be supplemental protein. This could be suggested in case where the oral intake cannot fulfill the requirement of protein and there is a fall in the growth centile. These are some of the preparations that is available. And in our center, RenoPro HP is used, where the calorie for 25 grams of the powder is 122 calorie, protein is 5 grams. There is no phosphorus and it is low in potassium and sodium. There is also option of enteral feed, where the evidence shows that there is significant increase in BMI in children on PD who are less than 2 years as well as more than 2 years who are started on enteral feed. Catch-up growth was also noted in these children at a follow-up of an average of 1 to 2 years. Oral intradialytic feed, again, few studies have reported that 70% of the children subjectively felt better when their intake of small meals or snacks during the sessions of dialysis. Intradialytic parenteral nutrition, again, the KDOQI has recommended a small trial of IDPN to augment an inadequate nutritional intake in those with BMI less than 5th centile on maintenance dialysis who are unable to fulfill requirement through oral or tube feeding. When there is more than 10% weight loss, persistent hypoalbuminemia, or an NPCR rate of less than 1 gram per kg per day. Coming back to Anvita, she presented again to our center 3 months after the first event, where she had a critical event of bronchopneumonia with global LV dysfunction, requiring invasive ventilation and inotropic support for a duration of 24 hours. Her CAPD cuff had an extrusion. There were 2 episodes of CAPD cuff extrusion, and there was poor abdominal muscle strength. She required a reinsertion of CAPD catheter. Her oral intake had drastically reduced over the last 3 months, and there was a weight loss of 1.5 kg over 3 months. She also had regression of gross motor milestones, and there was apathy. On her calorie assessment, she had 80% deficit of calories and 60% deficit in protein, with a significant weight loss from 7 kg to 5.5 kg in 3 months. There was a drop in the standard deviation for weight for age, height for age, BMI for height age, as well as mid-upper arm circumference. She was severely pale. She had generalized wasting. Her CAPD cuff was extruded with poor abdominal muscle tone as well. On follow-up, her growth chart showed a significant fall in the weight centile. There was a drop in her height centile, as well as a drop in the BMI for height age as well. She had severe anemia, hypokalemia with symptomatic hyponatremia. Her serum albumin had dropped to 2.3. She had hypocalcemia. Her phosphate levels had dropped to 3.8. PTH was suppressed at 80, and she was iron replete. How did we manage her? Apart from the initial stabilization in the ICU, we targeted aggressive nutrition once she was stabilized and shifted out of the ICU. We started with nasogastric feeds with F75 feeds with gradual increase of volume. We were able to achieve 6-hourly feeds with the targeted calories of 500 kilocalories per day and a protein of 1.5 gram per kg per day over a duration of 2 weeks. Regarding her CAPD, her PET, which was done previously, showed a high average transporter. Her PD catheter was reinserted. PD was optimized to 1.5%, 1 bag of PD with 250 ml of dwell volume, 2 hours duration, 8 cycles. She achieved a UF of around 500 to 550 ml per day, and there was a significant drop in her residual kidney function to less than 100 ml per day. Symptomatic hyponatremia was managed, and for hypokalemia, we withheld her ACE inhibitors, optimized her PD, and initiated her on oral K-bind. Her nutritional plan of management for a weight of 6 kg, we made a plan for an expected energy expenditure of 447 kilocalories, protein of 7.8 gram, and a fluid intake of 600 ml. For enteral feeds and for TPN, 2 plans of management were made. For enteral feeds, we targeted F75, which gave a calories of 75 kilocalories, protein of 0.9 gram, lactose of 1.3 gram, and a potassium of 3.6 millimoles for 100 ml. Started with 50 ml of F75 every second hourly to give a calorie of 450 kilocalorie and protein of 5.4 gram. We also had a plan in mind of a total parenteral nutrition with preparation of Cabiven, with 1440 ml providing a calories of 1000 kilocalories, protein content of 34 grams, lipid content of 60 grams, sodium of 32 millimoles, and potassium of 24 millimoles. 640 ml of Cabiven provided 450 calories, 15 grams of protein, 0.2 gram per kg per hour of lipid, 2.3 milliequivalents per kg per day of sodium, and 1.3 milliequivalents per kg per day of potassium. Coming to the third question for the audience poll, what could have been an appropriate ideal approach for the dietary management in this child when she presented 3 months later? Option A, whether total parenteral nutrition. Option B, a stepwise approach of tube feeding and transition to feeding gastrostomy. Option 3, direct enteral feeding. And option D, partial parenteral nutrition with tube feeding.
I think we'll end the poll. The stepwise approach to tube feeding and transition to feeding gastrostomy to 67%. Next is 27% of the audience say partial parenteral nutrition with tube feeding, and 7% say TPN, and 0% direct enteral feeding.
So the answer here will be open for discussion at the end of the presentation. So what we chose is a stepwise approach of tube feeding, and we made a plan for transition to feeding gastrostomy. The other parameters of CKD were managed appropriately. Anemia, we gave her a PRBC transfusion and optimized her EPO. For CKD-MBD, treated her hypocalcemia, withheld her phosphate binders. Hypertension, she required reinitiation of antihypertensives and optimized to 3 medication. And at the end of her ICU stay, there was an improvement in her ejection fraction from less than 25% to 50%. And she also had a concentric LVH. Going back to the recommendation by the Pediatric Renal Nutrition Task Force, regarding the enteral feeding, the recommendations answers 3 questions regarding when to start enteral feeding, what is the type or what is the mode of the feeding that could be chosen, and how to go about the type of feeding. So regarding when to start the feeding, The supplemental or exclusive enteral feeding should be initiated when there is an inability to meet the requirements orally. Prompt intervention becomes important when there is a height and weight centile loss. The type of feeding could be nasogastric tube feeding, which is a short-term therapy and a bridge therapy, or it could be gastrostomy, which is a long-term therapy which requires preparation and appropriate gastrostomy devices. And it is important to plan this gastrostomy with respect to peritoneal dialysis. Again, the type of feeding, whether it is tube feeding or enteral feeding, has its own role with complications as well. What can be done prior to the initiation of enteral feed? So if the child is stable and has an oral intake, it would be important to increase the feed concentration and to make it more energy dense. We could tackle the gastroesophageal reflux by adding the prokinetic agent. And in the weaning period during infancy, it becomes important to avoid the food aversive practices. Regarding initiation of tube feeding, as per the guidelines, it's a short-term method suitable in weight of less than 4 kg, and it's a simple procedure without any risk of peritonitis. The disadvantages being an increased risk of trauma, inhibition of oromotor skills, increased risk of GER, aspiration, and rare cases perforation. With respect to gastrostomy, it's a long-term procedure, more socially acceptable, with less episodes of GER and trauma. The disadvantages being tube blockage, replacement, balloon rupture, there can be displacement of the tube, tract closure, skin irritation, risk of hemorrhage, and in percutaneously endoscopically inserted gastrostomy, there's a risk of peritonitis and gastrocolic fistula. A few words about gastrostomy. The method of insertion could be radiologically inserted, that is a percutaneous endoscopic gastrostomy, or radiologically inserted gastrostomy. It could be open procedure, that is Stam's procedure, or percutaneous laparoscopic assisted gastrostomy. Again, the timing of insertion depends upon whether the child is on peritoneal dialysis or not. If the child is not on peritoneal dialysis, then PEG or RIG could be the method of insertion of the gastrostomy. If the child is already on PD, or if a simultaneous insertion is planned, then the percutaneous laparoscopic assisted gastrostomy or open procedure can be planned. However, the PD catheter exit site should not be over the stomach. It is important to know that there is a risk of peritonitis, especially in case of the percutaneous endoscopically inserted gastrostomy or the RIG procedure. And also there is an increased risk of exit site infection if there is a closed site of gastrostomy as well as a PD exit site. Preventing this perioperative complication becomes important. One is the role of antibiotic prophylaxis in a child who is planned for gastrostomy, depending upon the local sensitivity. If the child is already on PD, in addition to the antibiotic prophylaxis, it becomes important to add antifungal prophylaxis as well. While on PD, important to withhold the peritoneal dialysis for a duration of at least 24 hours, and initiation of feed with water bolus with gradual formulae, it could be done as early as 2 hours, and it can be gradually increased every 6 hours. There has been various evidence on enteral feeding in case of children on peritoneal dialysis. Two important studies that I would like to highlight is one by Rees et al. In 153 children aged less than 2 years, where 54 children were on nasogastric tube, 10 were on gastrostomy, 50% on NG feed were switched to gastrostomy. There was a significant improvement in the median height standard deviation at the end of 1 year with nasogastric tube as well as with feeding gastrostomy. Marles et al. Looked at 50 children aged between 2 to 10 years and found that majority of them were on gastrostomy, and at the end of 2 years, they had significant improvement in their height standard deviation as well as the BMI standard deviation. So the enteral feeding in children with the available data has shown an improvement in height and weight as well as the BMI standard deviation. In case of baby Anvita, we faced quite a few challenges. One was the management of nutrition itself. The need for partial parental nutrition was considered and kept as a standby. However, we did not implement it. And there was a difficulty that was faced with the NG feeding. The repeated episodes of insertion of NGT and the need for optimizing calories and proteins were also challenging. Whether opting for feeding gastrostomy would have been a better option here, again, is an open question. But we faced an important issue of having family issues in decision and compliance regarding the feeding gastrostomy, as well as the CAPD. We had a steady follow-up data over the next 1 year. With respect to nutrition, the child was gradually weaned off on NG feed. She did well on NG feeds, and she started tolerating the home-based diet. And at the end of 1 year, we were able to achieve a calorie deficit of 35% and protein deficit of 30%. And end of 2 months, we could remove her NG feed as well. She showed a steady increase in her weight and height centile over the period of 1 year. She significantly improved in terms of her developmental milestones, and her CAPD and medication compliance with respect to the family members were also improved. Thank you.
Right. Thank you, Dr. Swati, for that wonderful presentation of the case, and very informative indeed. Especially those who are not into pediatric nephrology, I'm sure it must have been very, very informative. And we'll take up the questions after the second lecture. So we'd like to invite Dr. Arpana Iyengar for her lecture now.
Good evening to the organizing committee of the WIN, Dr. Urmila Anand and Dr. Manjusha, to our moderators for today's session, and all of you delegates who have decided to log in and spend your busy Monday evening with us. So, as you have just listened to Swati, she beautifully described how challenging management of a child who is chronically on dialysis is in terms of improving her nutrition. And what we're going to do now is to actually step back and look at the assessment of nutrition status in children on dialysis. So let me kickstart with this slide. This was a survey that just came out a couple of months back. It was a survey that was conducted by the ISN and the ISRNM, and it was a global survey. So there were several countries involved, and you can see here, the question is, was formal assessment of nutrition undertaken for patients with CKD? Of course, this is an adult study, and you will observe on this slide that in low middle income countries, only 40% had formal assessment of nutrition status in comparison to 75% in high income. Of course, I think all of us would have expected 100% in high income countries, but this is the reality. What next? Who does these formal nutrition assessments? So if you look at high income countries, 51% were nephrologists. In low middle income countries like ours, 76% were nephrologists. We also had a small proportion of nurses and nutrition technicians. But you look in high income countries, 47% of nurses also were actively involved in assessment of nutrition. What else? So this graph simply says that if you look at all the blue bars, it says that whatever you're assessing is always done. For example, finding of a documented nutritional assessment overall was only 14%. Dietary prescription to patients with CKD was given always overall in 8%. Dietary adherence of patients with CKD was assessed and documented overall in 5%. So look at this big challenge we have before us. It's not about whether you are in a low income country or low middle income country. Even high income countries have a big challenge in assessment of nutrition in their patients, in adults. So you can imagine what would happen in children. Though I should say, as pediatricians, we undergo a lot of training with respect to nutrition in our MD course. So we are, it's part of our clinical, evaluation, and it comes readily when we look at a child. But sometimes we are so overwhelmed with all the other comorbidities that nutrition just goes backstage. I had an opportunity to write an editorial along with Dr. Valerie Lukes on accessibility of nutritional care, and we alluded to the survey. And what is the solution? So in this editorial, we discussed the various solutions to bridge the gaps that we had just seen in that survey. And one of the proposals was to have a schematic process wherein, you have a model of train the trainer. This is not new. All of us have had this in various WHO programs, especially as pediatricians. And this model would aim to build a pool of competent instructors. Instructors, are not individuals, but pairs of nutritionists and the nephrologists. So if we have something like this, because we got to train our nurses, train dietitians, and I think Dr. Anita Saxena is doing humongous work in that field of training several dietitians every year through her workshops. So this has to be disseminated across the country, and more importantly, we need to focus the same kind of module and training for pediatric renal nutrition. Some of the pictures of our kids. This is a girl who's 7 years old, just weighing 12 kgs, which is really low for the adults here. And she's on chronic PD. She's got hyperoxalosis, and she is not going to get a liver kidney transplantation. So the parents have decided to continue PD for years. This is a boy who came with post-urethral valves. He had gone to nearly 10 different doctors and came to us in this state. And you can see how emaciated and morbid he looks. This is Anvita's tummy, where you can see the extrusion of the cuff because there is no subcutaneous fat, and she was really undernourished. And this is the other side of the spectrum, not commonly seen by us, at least not in St. John's, that you have overweight or obesity as a part of the spectrum. So actually, when you talk about the term malnutrition, it comprises of two entities. Undernutrition, which could be stunting, a combination of stunting, wasting, underweight, micronutrient deficiencies like you heard from Swati, or overweight and obesity. So together, this is called malnutrition according to the WHO. What we are going to do today is focus more on undernutrition because that is what is commonly seen. So if you look at all the CKD comorbidities and you want to know how are Indian kids different from the West, and to refer to the West means to refer to the CKID study because that's the largest cohort of CKD children from North America, and the largest study includes 528 to 600 kids, you see. So the numbers are always small when it comes to pediatrics, and you adult nephrologists are used to huge numbers. Our study had 78 kids, and we tried to look at the prevalence of various comorbidities. And if you see here, vitamin D deficiency, we had higher proportions, left ventricular hypertrophy, 45 versus 15, short stature, 50% were short in our cohort. Dyslipidemia, again higher than the CKID study. But when it comes to obesity, we had only 1%, whereas that is quite a big problem in the West. Now, when you are talking about nutritional assessment, be it adults or children, we do have challenges, right? Because we don't have a single tool that is ideal for assessment. Wish we had one, then there would be no discussion. There would be no further research. So in one way, it's good because of this fact, there is more opportunity to keep exploring and find out which is that reference parameter that one would use in the future to say the child is undernourished or overnourished or normal. So the changes in the body composition, this is more relevant to pediatric or children because they're growing and therefore the body composition can change with age. Edema, common to adults and children, can come in the way of nutritional assessment. Etiology of CKD, like in children, we have majority of them having non-glomerular etiology for CKD. like Caput and other chronic tubulointerstitial diseases. And therefore, they are short even before they get on to the ESKD category. They are short, they can have bony deformities. So the etiology does make a difference in the assessment, and we got to keep that in mind. Medications can affect growth. Many of our kids who have FSGS or who have been on long-term steroids and then have progressed to CKD can have short stature due to these medications. So comorbidities like short stature itself or bent bones, CKD, MBD, these by themselves can come in the way of a very precise nutritional assessment. And as I said earlier, there is no single tool that is ideal to diagnose undernutrition. So the question from my side would be in the nutritional guidelines. So we have two guidelines. One is an old one. It's called the KDOQI guideline of 2009. And recently, the Pediatric Renal Nutrition Task Force, that's a European group led by Dr. Roxana Shroff from Great Ormond Street Hospital for Children, London, has brought out assessment tools in children with CKD. So these two are our kind of reference papers that we look at the various parameters. And I would like you all to either choose or guess which parameter is not recommended as a parameter to be used to assess nutrition status in children with CKD. Okay, we'll end the poll here. Weight for age and mid-arm circumference are almost equal. The answer is mid-arm circumference. So as pediatricians, we are quite used to having mid-arm circumference as an important parameter, but we don't have enough evidence to say that it is useful in children with CKD. So these guidelines mention that we need to study the mid-arm circumference, the utility of MAC in these children. So this particular parameter is not a strong recommendation. Let me go to the next slide. So what are the anthropometric measures or parameters that these guidelines suggest? Dietary intake, height for age, height velocity, estimating dry weight. Let's keep this in mind, the word dry weight, weight for age, BMI for height age, because these children are short. So in adults, you don't have this problem. You just express BMI as BMI. We have the BMI that is indexed to the height because these children are short. So this is specific for children with CKD. We use BMI for height age in those who are short. Head circumference and NPCR in adolescents on hemodialysis. So this is what, in a nutshell, the guidelines suggest. Now there are a lot of limitations in anthropometry and biochemistry that I think all of us know. So I will not go into the details. Whether you take dietary intake, there could be underreporting. Serum albumin could be underestimated because of fluid overload. Height, weight, MAC, skin fold thickness, any of these anthropometric measures could be overestimated in the presence of edema. So let me now bring you into a different world of body composition. When you listen to body composition, at least a few years back, I would think that it's too complex. And I never felt that I would understand or it would be useful for a clinician. But let me try to make it easy for you all. If you think that this is the body weight, this bar, then the body, whole body, is made up of broadly two compartments, the fat-free mass and the fat mass. Now, the fat-free mass has cellular tissue mass, bone and other non-active components, and mainly the total body water, which can be further divided as intracellular and extracellular water. And the fat-free mass also has the extracellular mass and the body cell mass. So let's remember this diagram. I'm going to put this again in a different context, but it suffices to say that if you're looking at anthropometry here, be it mid-arm circumference, body mass index, or skin fold thickness, what are these measures actually reflecting? If you look at the body composition, they are just reflecting both fat-free mass and fat mass. That is, mid-arm circumference and BMI are a combination of FFM and fat. So you cannot split the fat from fat-free mass. It's important, isn't it? You want to know whether the fat percentage is more or the fat-free mass is more in a child who is having CKD. So these two anthropometry measures do not allow you to split the two. They just combine both, and you may have a low MAC or a low BMI for height age. Skin fold thickness, yes, that is directly telling you about the fat percentage. Okay, so this is just for adults who happen to see children and are involved in pediatric care, that there are many guidelines that have been put forth by the Pediatric Renal Nutrition Task Force in the last 2 years. And I just listed out this because it would be important for you, in case you need to look at it, to go back and refer to any of these. Now let me shift gears and look at PEM versus PEW. So you just invert the M and becomes W, right? But these are two very, very contrasting entities. Protein energy malnutrition. It's a very, very familiar term to any pediatrician. You are seeing a child who has reduced fat stores. In protein energy wasting, that most adult nephrologists are very familiar with, because it all started with adult data, and as always, then it slowly trickles down to pediatrics, and we start extrapolating all that from all the guidelines, all the criteria. When we don't have enough evidence, we extrapolate it from adults. So this protein energy wasting originated by the ISRNM more than 1.5 decades ago. And in this entity, you have preserved fat. In protein energy malnutrition, you have muscle which is preserved, but here there is muscle loss. In PEM, there is decreased metabolic rate. Here it is a hypercatabolic state, right? CKD. In PEM, the child will be very hungry. So it's easy to have nutritional rehabilitation undertaken, but in children with CKD, they could have decreased appetite. And here there's a good response to supplementation, whereas we usually are disappointed because response to supplementation may be variable and may not actually help the child gain weight. So the reasons are quite obvious to an adult nephrology crowd, because in CKD, undernutrition is not only because of decreased dietary intake. Many of our kids have appropriate dietary calorie intake and protein, but are still stunted, are still undernourished. And that is because of the uremic milieu with a lot of components of inflammation and other oxidative stress and so on, which add to the existing undernutrition. And therefore, PEW does not respond to only nutritional rehabilitation, though we need to take that as a first step in our management. So I'm not going to go through this in detail, because all of you as adult nephrologists are familiar with your criteria for PEW. But as I said, we've just tweaked it a bit, and Abraham et al. In 2014 proposed this criteria, which has 5 different domains adapted from your adult criteria, and then added domains that are very specific for children, like poor growth. So based on this criteria, you can actually classify PEW kids as mild, standard, and modified. It depends on how many criteria they fulfill. So the question now to audience is, name the component that characterizes PEW and not PEM. We just did this, so it should be easy. Okay, I think this is not the Siddharth, this is not the poll, but let's not waste time. No, not this. So I think it's got missed, but let me give you the answer. We just did this. It's high metabolic rate, right? That's what's seen in protein energy wasting, and you don't see it in PEM. So we undertook a study on PEW, and this is published in the Journal of Renal Nutrition. In children with CKD 2 to 4 and those on dialysis, 58% had PW. And what was interesting is that we had those 5 domains I showed you, but which domain was most useful in diagnosing PW and classifying the severity of PW? It was appetite and anthropometry measures. So those biochemical criteria, which is like cholesterol, transferrin, you have it in your adult criteria too. Cholesterol, transferrin, albumin were not useful in diagnosing PW. And inflammation, which is detected by the CRP, which is again in the PW criteria, was common but was associated with the wasting only in early stages, not in children who were on dialysis. So again, comparing us to our reference gold standard study, that is CKID, our burden was much, much higher in terms of PW compared to the West. And that's not surprising. What is subjective global nutrition assessment? Again, very familiar to adult nephrologists. You call it SGA, we call it SGNA, because SGA is small for gestational age. So they didn't want pediatricians to get confused. So we said we'll call it SGNA. And then this is again a very elaborate assessment. Sounds good when I talk today, but I'm sure our dietitians and residents who sometimes are asked to assess, go through this and take a lot of time to assess, because you have 10 parameters: nutrition focused medical history and nutrition focused physical examination. And I'll not go into the details. These are all subjective scores. And finally, you come to a total score that says, is the child normal? Does the child have malnutrition, moderate or severe? So this is the way you assess SGNA in children with CKD, and not many studies have been done. We undertook a study in children. Of course, in adults, this is a valid reference tool to assess PW in adults. But in children, there are hardly any studies. So we undertook this study and found that in dialysis, children on dialysis, about 41 of them, 2/3 of them were diagnosed malnutrition by SGNA, and majority remained in the same category on follow-up. The follow-up was between median of 8 months, so not very long follow-up. And only half of these SGNA parameters were strongly associated with the presence of malnutrition. So though we go through those 10 parameters, all of them are not really useful. So again, there's an opportunity to relook at these assessment criteria and probably reframe it as we go by with more evidence. What is nutrition focused physical examination? This is coming up in a big way in the last few years, especially incorporated as a curriculum for dietitians, be it renal dietitians or general pediatric dietitians. So you have 3 domains here: subcutaneous fat, muscle wasting, and edema. And one may wonder, what is there so much to look at? Is there fat loss, muscle loss? Oh, the child looks so thin and skinny. Obviously, there is, malnutrition. But look at the systematic way in which these domains are looked for, meaning in physical examination. You look at certain areas for subcutaneous fat loss, you look at other areas for muscle wasting physical features, and also you examine for edema. So this is designed or created for dietitians, for paramedical workers, and not specifically for nephrologists. So can nutrition focus physical examination? Suppose you're in the community and you have a center there, you're screening patients for CKD. It could be adults, it could be children. Do you think that physical examination as a point of care assessment tool can detect the risk of, can predict the risk of a PW and diagnose PW? So we did this study. It's just gone out, submitted for publication. And definitely we found a significant difference in the parameters of physical examination in those with CKD and those on dialysis. And the sensitivity and specificity by looking at both physical examination of muscle wasting and fat loss were quite good. So it probably can be tested out there in the community instead of using PW, which requires blood sampling which may not be feasible there. Now, coming back to my favorite diagram again, now we're going to say that we have other tools like BIA, which can detect TBW, which can also detect FFM. DEXA is the reference tool for fat. It's also a reference tool for lean mass or FFM. It's a reference tool for bone mineral density. But what we are also interested in, and this is something new that I'd like to share with you all, is body cell mass. What is body cell mass? Body cell mass is the most actively metabolic tissue or compartment of the body. It's energy rich. It's the tissue that consumes oxygen. So if we have to look at nutrition in a more broad perspective, in a more functional manner, I would say BCM would suggest whether the child is nutritionally normal or no. Instead of taking all the other compartments in the body, can't I just target this body cell mass? We'll look at it in a bit. You're familiar with this bioimpedance, and we looked at whether body fat deficiency in kids with CKD is really prevalent, and we concluded that in a small number of children, which included both dialysis and CKD kids, that low body fat was only seen in about 12 to 18%. So most of our kids, though they have a low mid-arm circumference, meaning they are malnourished, but their body fat is well preserved. And that's exactly what we hypothesize when protein energy wasting occurs. Okay, this is a graph that I would like you all to see. Take a quick look, and the question comes after this. Is the poll working, Siddharth? Thank you.
Yes, ma'am.
Okay, that was nice. Before somebody clicks the other options, I'll change. That was good. 100% said BIVA. And I think we have the girl who really worked on BIVA, made it her thesis, her original work. And that is Soumya Reddy, who is another bright DM student who is going to give exams in a couple of months. So the bioimpedance vector analysis that you see here, you all know, as adult nephrologists, I don't need to explain, was useful for us to track dry weight. It's very important to get euvolumic weight. So you do it pre-dialysis, you do it post-dialysis, and this is for hemodialysis children. And you can see that you can track them and see that they go out of the overhydration compartment and go towards the reference curves, which is created based on normal, healthy, age-matched children. So this was in hemodialysis patients, and this is Soumya Reddy, our DM resident's thesis work, which again she used BIVA, created the normative reference graphs, and then plotted the resistance and reactive indices on the graph, and tracked children on chronic PD longitudinally for a couple of months to see how their status of hydration would change. So this would be one important tool that adults, I know you have many studies, but in children could be employed and studied further. Now, did you all know that we emit gamma rays? I know you'll all be surprised. What am I talking about? Yes, we do. And how do we do that? Because we have naturally occurring radioactive potassium-40 within our cells. All of us do. As we are all sitting here, we are emitting gamma rays. Isn't that cool? So we also know that potassium, 98% of potassium is intracellular. So what if I have a tool that can detect this intracellular potassium, because it's radioactive, so I can detect that, and probably I can use that to reflect the body cell mass. So I told you how important body cell mass is. So very few centers in the world, there are only 5 centers that have this equipment called the whole body potassium counter. And I'm fortunate that the Division of Nutrition of St. John's Medical College and Research Center has this state-of-art facility wherein we undertook this study to look at the estimate the body cell mass in these children with CKD and those on dialysis. And some preliminary results here, like you would expect, the body cell mass, that is indexed to height, so I call it BCMI, was significantly lower in children with CKD than healthy controls. We had 20 healthy children who were sweet enough to come and help us with our reference values. And BCMI was lower in CKD kids 2 to 4 compared to those on dialysis. But are you going to, am I telling you all that, okay, use this tool? Of course you can't, because this is not a clinically friendly tool. This is a research tool. So my next step is to see which of these anthropometry measures would closely correlate with the BCMI. And probably then we could say that, okay, we are getting close to referring to one single tool to assess nutrition status. Frailty is something that you all as adult nephrologists seen, especially in the elderly, but let me tell you that children also are frail. Frailty has been seen in the CKID study using various criteria, and muscle strength has been linked to cardiovascular outcomes, and a low hand grip strength has also been linked to many other comorbidities in children. So we are getting there, few studies, and we hope to do some original work in our center too in the near future. Next question, the poll please. So it's in the same order as the picture. Okay, we'll end it here. Yes, I guess that 2 would be what most would think, but some of you have also opted for 3, which is the right answer. So there's nothing like non-vegetarian as a term. So it's omnivorous, flexitarian.
Ma'am, I think we have low network connectivity at Arpana ma'am's and she logged out somehow.
Meanwhile, can we take some Q&As while she logs in back?
Yeah, ma'am, it's bottom down.
Yeah, sure. So Dr. Urmila Anand ma'am has this question. Is the CKID cohort data about higher intake than recommended valid for Indian kids? I think Arpana ma'am has already answered that. She says, yes, we have also found that calorie and protein intake are adequate in majority despite being undernourished. Most of the questions, I think. Arpana ma'am has answered most of the questions here. Yeah, Dr. Manjusha Yadla ma'am has a question. Is there a possibility of PD failure apart from peritonitis after gastrostomy? Dr. Anita Saxena ma'am, do you want to take this?
Yeah, if I can just answer that question on behalf of Dr. Arpana. We usually do have peritonitis in the context of, starting a PEG or something while the child is on PD. PD failure as such doesn't happen, and so often peritonitis is the only complication that we see along with the child on gastrostomy, and that too, as Swati rightly pointed out in her study, it's mostly with the percutaneous technique while the child is on PD or not leaving a good enough period from a PEG procedure to initiation of PD. Otherwise, PD failure as such doesn't happen. It's peritonitis that we are concerned about.
Thank you. Dr. Sayali Thakre has this question. What is the common practice for starting dialysis in children who are undernourished? Are the EGFR thresholds higher? Is dialysis started earlier for these children?
Again, practice varies from center to center. It also depends on the availability and the feasibility of starting dialysis in a patient. But if malnutrition or, as Madam pointed out, protein energy wasting, or we are looking at more muscle wasting in a child, we might consider early initiation regardless of the GFR. Sometimes we might start even at a GFR of, say, 15 or 10, wherein otherwise we would push it to maximum. Nowadays, we do not start early dialysis. We try and push it as much as possible. But it again depends on the center-wise preference and the feasibility and the affordability of dialysis. But definitely malnutrition or struggling with, when there is a centile loss or something like that, we would definitely consider dialysis as one of the options to stop that protein energy wasting.
Dr. Prabha has this question. Is malnutrition inflammation score better than SGNA?
I would leave that question to be answered by Dr. Arpana. I don't think I would be able to answer.
Well, can I answer this?
Yeah, please.
Well, the thing is, a malnutrition inflammation score is exclusively for patients on hemodialysis, because it not only takes into consideration the entire SGA, but also it has 3 more components like serum albumin, transferrin, and the vintage of the dialysis. So I think for a dialysis patient, this is, I have not done this otherwise, but the SGNA that you are talking about in the dialysis patients, but I think we've been following a malnutrition inflammation score in our patients, and it is definitely a much better score compared to plain SGA.
Dr. Manjusha Yadla ma'am has another question. How feasible is it to do BIVA in children with CKD in all LMIC settings?
Again, the availability of the machines and pediatric specific machines. So those are also, wanted in, for example, we do not have that one in our own center where I practice. But few centers in the country and certain good centers do have that. So it's not a luxury that all of us can afford, but it's a definite and a very important tool in our assessment. And especially when you're struggling with a child on dialysis, where it's your between fluid overload, whether you want to remove more fluid or it's nutrition related. So all that, it is very important. We sometimes do refer a couple of patients to other centers to get this BIVA, the bioimpedance measured and take decisions accordingly. It's a very useful tool. But as you said, it's not a luxury afforded in all centers and especially not in low MIC.
So BIA is not only giving you the compartment, the lean and the fat, but it's also what Dr. Iyengar was talking about, potassium counter, and the potassium content also gives the potassium content, the calcium content, the mineral content. So this is very, very advantageous, and plus it's non-invasive. It's very easy to do, bedside friendly tool. I think I would recommend using this in patients.
I think Dr. Arpana ma'am is back.
Sorry for that. Siddharth, again, my video is not on, but that's fine. I'll just continue because I don't want to delay.
Please try now. Now it will be on.
Okay. Yeah. Okay, so we were talking about the plant-based diet, and we said that it really didn't make a difference to the progression in the CKID study. Quickly going through some of the key findings or studies that we have done in our center. This is again a thesis, a work of our DMA resident, Dr. Rena. So we looked at the assessment of dietary phosphorus intake and implementation of a parental phosphate education for children in CKD. And as expected, hyperphosphatemia was, high or prevalent in a majority of these kids. But over time, with the parental education, we found that the serum phosphate did reduce significantly over a 6-month period. And this is something that we are happy to share, because this is created, and it's a very original pyramid, phosphate pyramid, because most of us, and even in adults, we use the Italian pyramid. So this is not really relevant to our community and families. So we looked at the phosphate content of various foods, referred to the NIN documents, and prepared this pyramid that has got accepted in the IJN. And so you could all refer to this if you need. This is also applicable to adult patients. The last question for the day is, which one of these has the least phosphate to protein ratio? I don't know if you're all hungry, because we are heading towards dinner time. So obviously choice 2 is now increasing based on your appetite, but it's egg white. It's not the yellow part, it's the white part. So the answer is egg white. And that's very important for children, because in adults, you're not bothered about protein supplementation. You are all looking at restricting proteins, and as pediatricians, we are looking at giving normal proteins, or in some instances, higher proteins. So we always look at the phosphate to protein ratio, because we want the least ratio, and egg is a perfect food in terms of maintaining low phosphate and giving biological value protein to the child. Okay, thank you. I'll just put off the poll. Compared to fish, which is around 11. So the phosphate to protein ratio here is 1.7 in egg, it's 11 in fish, and 27 in curd. This is just for the trainees. So an egg a day keeps the phosphorus away, because it is highly digestible. The cooked egg has good calories and proteins, low sodium. It's rich in leucine for muscle protein synthesis, and has low net acid load. And we say that egg white is helpful to control hyperphosphatemia, and it's a good source of proteins. But let's remember that the yolk is not that bad. It's also got some good features that will help children improve their nutrition. You must have all read this editorial that was quite attractive, because you see the apples there. In transplanted adults, higher dietary acid load was associated with progression of kidney graft loss. Well, again, it just stresses the fact that an apple has a lower net acid load, lower phosphate, so it's good to have apples. Of course, if you're really worried about the potassium, it shouldn't be a major concern. So apple has good properties, and this is what the editorial reinforces. We undertook randomized controlled trial, a multi-center one with 4 centers in India, and you can see the names here. Again, we had involved one of our DM students, I think, who is there in the audience, Hamsa Reddy. So this RCT, again, the conclusion was, use the daily dose, use weekly dose, use monthly dose of vitamin D. But if you give a cumulative dose of 3 lakh units, 3 lakh international units, it doesn't matter whether you give it daily, weekly, or monthly when it comes to the replenishment of stores, that is 25 OHD coming back to normal. So again, this is part of nutrition, because we should be looking at supplementation of vitamin D, and as in adults, we are aware that vitamin D is a critical component in management of children with CKD and on dialysis. Growth hormone recommendations, I'm sure as adults you would like to know this, especially adult trainees, because you would be faced with children sometimes in your bedside presentations. growth is something very unique to children, so you don't even bother about this in adults. And according to the guidelines, recommendations of 2019, these are the indications for growth hormone therapy. Is metabolic acidosis associated with progression? Again, you have a lot of data there in adult world, but in pediatrics, we have 2 or 3 studies. The 4C study, which favors supplementation of bicarbonate because it helps in reducing the CKD progression. In the CKID study, again, participants with glomerular disease who had bicarbonate on the lower side had a higher hazard for CKD progression, and bicarbonate less than 18 was linked to greater risk of CKD progression in those with non-glomerular disease. So this is the data that we have in pediatric CKD. Now, there is a formula, I don't know how many of you are really using this. It's called PRAL. It's a dietary acid load. The dietary acid load is measured by PRAL, which is the potential renal acid load, and this is the formula that is used to calculate that. So we want to know what is the dietary component of the acid component in the diet. And just as a pilot study, we looked at the dietary component of acid by using this formula in 31 children on dialysis. And if you can see here, if the PRAL is positive, it indicates that there is acid. If it's negative, then it indicates that it's got more base. So you would wonder that if children are more vegetarians, then you would have lesser PRAL, that is negative PRAL, and those who eat more of non-veg would have higher PRAL. But you see in our kids, whether they're on dialysis or not on dialysis, most of them had PRAL which is on the positive side, which means there could be, this is just a preliminary pilot data, there could be evidence to say that our kids also have a higher acid load. So when we probe into their diet, what do as mothers, or you can see your own family members, if you have kids at home, you see what they eat. Our kids on history, they say rice and rasam. Now what does that contain? Fruits, not much. Vegetables, no. The vegetables will be taken away and put to a corner on the plate. So you see all those foodstuffs which actually have potential to decrease the PRAL are not being eaten, even if you're a vegetarian. So we found that kids are not being on a very balanced diet, and probably that can contribute to this. And lastly, I had an opportunity to write this opinion paper for the Frontiers, wherein along with Dr. Robert Mack, who is again a very well-known researcher and clinician in the pediatric renal nutrition world, we put forth the gaps and opportunities for research in terms of nutritional assessment tools. And we brought out a very comprehensive table that shows us what are the available tools, what are the merits, what are the demerits, so that clinicians can look at it and choose what they would like to use in their context or healthcare context, various healthcare context. It could be tertiary hospital, it could be community, and so on. So I would like to end by thanking my whole team, my residents, the paramedical staff without whom such studies are just not possible, the nutritionists Sheba Collins, Rimsi, Paul, Shaila, Lobo, all of them stand like pillars for us in our both clinical and research activities. I would like to end by paying my respects and remembering this legendary figure, Dr. Leslie Rees. It's apt to remember her today, especially in this session, because she is known as the mother of pediatric renal nutrition. We just lost her a few days back, and she was a professor at the Great Ormond Street Hospital for Children for several decades. And because we're talking of nutrition today, I thought I should specially mention this and pay our respects to her. This is a photograph in 2003 when I was fortunate to meet her in person in London, and I'm sure Dr. Sukanya also has spent time with her during her fellowship there. Thank you very much. We are open for questions and discussion.
Thank you so much, Dr. Arpana ma'am, for such a wonderful and enlightening session. Thank you, Dr. Swati. It was a very good presentation. Thank you, ma'am. The slides were just amazing. We would love to hear comments from our moderators, Dr. Anita Saxena and Dr. Sukanya Govindan.
Well, all I have to say is the adult nephrologists have gained a lot from these two very explicit, something which is really is not in practice. We don't get to see so many kids as you do. You're just seeing kids. And so the information that you've given is enormous and very beneficial to everyone. There was a question, Dr. Iyengar, I answered in your absence, that would you...
Thank you for that.
Would you prefer an MIS or SGNA? Which one would you prefer for the dialysis patients?
So we don't have anything like the MIS for children. So you all have a lot of different scores. And the only score that is mentioned for pediatric CKD is the SGNA. And that too, we have only a couple of studies. So I think when you're talking about MIS, you are incorporating the inflammation component into it. Yes. And we don't have a score that incorporates that. So the PW has the CRP, the inflammation component, but the scoring tools don't have it for children.
But the PW will just say, well, it's there or not. But here you have serum albumin as well, the transferrin as well. So why don't you try doing this? Because this will be a good study, I mean, if you can include it.
Yes. So there was one study which included the biochemical markers with some of the anthropometry measures, meaning they just take a combination of both the domains and bring out it was called a BPNI score. So people have explored various score tools looking at combination of various parameters, and that definitely needs more study.
And one interesting question that was already answered was the adverse effects of gastrostomy on PD catheter, but it's basically the peritonitis, and peritonitis is something which is very scary. I mean, what worse could happen to a patient if he has peritonitis? So this is something we're always scared of. So what's your take on this?
I think Swati can answer this. We've had a couple of kids, I think 2 kids with gastrostomy. So it's not something that we do very often. Okay. Swati, would you like to answer?
Yes, ma'am. So regarding the incidence of peritonitis, as mentioned previously, the highest incidence is seen with the percutaneous endoscopic gastrostomy or the radiologically inserted gastrostomy. When compared to that with the open procedure or the percutaneous laparoscopic associated gastrostomy. In our center, we had 2 patients in whom we performed the gastrostomy procedure, but the incidence of peritonitis were not there in these children. Both the patients did not have any episode of peritonitis. And also the reported literature incidence is also not quite high. It is around, I think around 27 to 30%, but again, the sample size what we have is also lower. So probably will need more studies in children to report an actual rate of peritonitis following a PEG or a RIG procedure.
Right. Thank you.
There's one question: how different is dietary recommendation in children and adults? More omnivorous diet inclusion, non-veg diet recommended in children.
Okay, so as per recommendations, we usually have the diet intake based on age, based on weight, based on stage of CKD. So in adults, you don't need to use so many control parameters. So we do that, and there's no recommendation as to whether, because we don't have enough evidence to say that they should be they should have more of plant protein in children. Of course, we do understand the concept, and we do believe that it does make a difference when you look at evidence from the adults. So children are children. Whatever you say, they will like to take what they want. So on the contrary, they are also quite strict about maintaining their diet. So some of them, though parents say that we say that he could take this once in a way, the kid would tell, no, doctor has said not to take, so I will not touch it. So we have different, children with different approaches to their own diet. It's always a combination. In general, I think children who take both a vegetarian and non-vegetarian diet would prefer non-veg. Even on dialysis, parents would say he would eat chicken, but he doesn't want to eat any vegetable. So that is something we see commonly.
Dr. Manjusha Yagla has a question. What's the salt recommendation in different ages of children?
It doesn't depend on the age. Now, it depends on the underlying kidney disease. See, sometimes we struggle to limit salt in those who are, besides the usual, your world of glomerular disease, hypertension, salt restriction, we have these tubular disorders, kids with polyuria, polydipsia. Notorious example would be cystinosis, wherein we have to look at salt supplementation very carefully. Some of them have to restrict salt, which helps them restrict the fluid intake, and therefore that reduces the polydipsia and the polyuria, so that the calorie intake and food intake could be better. But in general, as the DASH diet recommends, we got to restrict salt in majority of children, which is quite difficult. It should be less than 2 grams or less than that per day, which is quite difficult. So we usually say no added salt, no cheese, sauce, papads, pickles, pizzas, all that actually nowadays kids like. We have to unfortunately say don't take that too often.
Ma'am has another question. What are the best tools of assessment of nutrition in LMICs with average infrastructure?
Manjusha, if you just give me some time to complete my study, then probably I can come out with the recommendation, if at all. There's still, I won't be able to say that there's a perfect tool for LMICs. We are looking at anthropometry. It's actually boiling down to anthropometry again. We may use many other assessment questionnaires and PW criteria, but then it's down to anthropometry. Now, which of those parameters, I need some time to complete and then probably come with an answer.
Anonymous person has a question. What's the best diet strategy for CKD children with a low acid load?
What is the best diet?
Strategy for CKD children with a low
best diet strategy to reduce acid load would be to increase the vegetable intake, increase some of the fruits, which would help, and keep the red meat and to the minimum, because that increases the acid. So basically, non-vegetarian food increases acid load, and red meat is notorious, but we cannot tell somebody not to change and become a vegetarian or a vegan just for this, but to also see that it's balanced with enough vegetables and fruits.
Are low diet acid loads available as recommendations? Anonymous.
They're not still recommendations made by any of these task forces yet, because we need more evidence. So what I showed you was just to stimulate some of you youngsters there who probably are looking for a good research question and saying, okay, I have got good number of patients with CKD, but what do I do? What should I study? So go ahead, take help of a nutritionist and look at the acid load in your patients. Very easy. You don't need blood sampling also.
Thanks for the tip, ma'am. How is the cost borne by parents in management of child nutrition? Is this high? Are there homemade foods which are easy to make and can be given to children? Again, Dr. Manjusha, ma'am.
Yeah, nice question. So this is our challenge in day-to-day practice. And you saw how Swati mentioned about F75, F100. I'm sure if Dr. Ruxana would listen to this, or anybody from the West, they would say, what is that? What is F75, right? So we are used to this because that is the freely available, low-cost rehabilitation food that is recommended by the WHO. And we use that in protein energy malnutrition when they're acutely requiring some calories. So we use that in this kid because this kid also couldn't afford anything more than that. So we hardly have the opportunity to prescribe all the commercial supplements. We do that in those who really can manage, but mostly it is home-based. So it costs a lot. So for them, adding to the cost and buying supplementation in addition to all the medications and dialysis bags and all is asking for too much. So we have to keep that in mind, and we somehow work around home-based diet.
I think we are done with all the questions. Any closing comments from the moderators or speakers?
Well, it's been a wonderful session. Totally nutrition and everything which is lacking in the knowledge in most of the adult nephrologists, because we have very few pediatric nephrologists. I think there are a lot of take-home messages from these two lectures. One is it's very difficult to even think how they manage a small baby of a year and 3 months old who's got failure to thrive, and the way the patient was not doing well, but then they put them on this PD, and then again the patient lost, and again they made the patient recover. So these are, this is the dedicated concentrated effort towards the patient and your involvement with the role of nutrition. So nutrition, as you said, sometimes we are, it takes a back step, but I think it should always be taken along with the treatment, and without that it's not possible. But yes, it's the most important thing when it comes to CKD and particularly dialysis is to, no matter how much you feed your child, no matter how much protein you try to give to your child, to your patient, it is the inflammation that has to be controlled, the most important factor. Till this mechanism of the catabolic mechanism is blocked, nothing's going to really help. So I do not know how you are handling inflammation in these patients, but do you have any comments on this? Are you treating inflammation actively? Metabolic acidosis is something we are taking care of every day, but what about inflammation?
No, in practice, we are not handling inflammation. I think we are still in the stage of looking at, what is the profile of inflammation in this wide spectrum from CKD2 to 5D. And therefore, it's all these questions, I think again, for youngsters, it's important because like diabetes in your adult nephrology world, I think undernutrition is something that we see so often. So there's no point waiting for Western guidelines to tell us what to do. We see that kind of burden here, and what we read in Western guidance may not be at all applicable. So let's start looking at, in our own small ways, looking at studying things systematically. I won't say research because that is, I think, an overwhelming word. So let's look at things more systematically, study our own patients so that we can come up with our own guidelines. I think Sukanya is taking that bold step by organizing a training for dietitians for the pediatric nephrology community, and so we need such kind of initiatives.
Yeah, what I'm trying to say is that we know the inflammation is there, and there elegant experiments on human patients have shown that hemodialysis is a catabolic procedure, and inflammation is blocked, nothing. So in your day-to-day practice, can you think of introducing something that would actually be able to control, knowing fully well that inflammation is there? Can you think of something which you can use to prevent inflammation, not to prevent, to control inflammation in these patients?
As far as drugs are concerned, none of them are really studied or approved in children. Adults, yes, you have various drugs, but none of them are. So all that we should keep in mind is we should prevent infections. Like most of our dialysis kids are on temporary catheters, they get, So that can again cause a chronic state of inflammatory state. So that is one way of looking at decreasing inflammation. But from a pharmacological point of view, we don't have any drug that is approved.
So Dr. Sukaria, would you like to?
Yeah, I would just disagree with the comment that it's mainly useful for adult nephrologists. But this session is such a a wealthy resource for all of us pediatric nephrologists too, because as I said in the initial comments, that work on nutrition is much lacking, and there's a huge gap, if not in the Western countries, more so felt in the lower and lower middle income countries like our region. So we need data and we need tools to which are specifically designed. And Dr. Arpana, there's no better person than Dr. Arpana who's leading the way for most of us. And with regards to the question on inflammation, although there's no particular drug or particular strategy or a single magic pill that would reduce the inflammation, the only thing that has been recently shown, or it's been well documented in certain studies, is using HDF as a modality for dialysis, wherein some of the inflammation, some of the middle molecule clearance can be facilitated and sort of bring down, although it's not entirely going to take care of all the inflammatory load or the cachexia and everything, but definitely seems to be helping in children. But other than that, there's a huge gap and a huge void there on tackling inflammation, especially in children, where there's hardly any research coming up. And congratulations to Dr. Arpana and Dr. Swati. It was a real wonderful masterclass in how you manage a child, in how you assess nutrition in a child, and definitely it's a boon. And I'm sure all the pediatric nephrologists here and all the nephrologists here would appreciate how wonderful this session was. So thank you so much for doing this session today.
Dr. Sukanya, there's one last question from Dr. Manjusha. What advocacy measures can be done to parents of CKD stage 2 to 5 children? 2 to 5 who are not on dialysis, 5 ND children.
I didn't get the question. What in CKD 2 to 5?
Non-dialysis children. What advocacy measures can be done to parents of CKD children who are not on dialysis?
Okay, so which means that how do we prepare these families for dialysis? I think that's quite for a separate session, I think. So it's difficult to answer in 2-3 sentences, but I think the key point would be to prime them early enough based on what the underlying etiology is, because when you have non-glomerular etiology, they take time to progress. So you have enough time. If the child is in CKD 2, 3, then you don't expect them to go to CKD 5 in a year or 2. But if it's a glomerular etiology, then they have fast progression. So depending on that, you will counsel parents, keep them prepared, give them information. It's important to do that, not only to make them aware, but also to prevent them from getting wrong information, either from rest of the community and by Googling themselves, right? So we have this issue also, and it's important to also look at the family structure, the family dynamics, because they would be a decision maker who would be important to be identified for further decision making. You also need to look at the financial resources, where they stay, the distance from the center. Now, these are some of the barriers that we have identified systematically and published a paper on barriers to transplantation, wherein we have identified many of these factors that make a big difference for a child to go ahead with transplantation or go ahead with dialysis. So a medical social worker would be required, dialysis nurse, a HD technician, a PD nurse, a child psychologist, a CKD coordinator. All these, paramedical staff or allied health workers are very, very important to strengthen the program of CKD. So it's not enough to just have nephrologists in the team.
Thank you, ma'am. Thank you so much. A lot of comments in the chat box. Wonderful session, great work. Congratulations, great job. And we're all looking for pediatric dietary guidelines for Indian scenario shortly. I thank Dr. Anita Saxena, Dr. Sukanya Govindan, Dr. Arpana Iyengar, and Dr. Swati Kiran Shiri for such an enlightening session on pediatric nutrition, especially for adult nephrologists like us. It was just an amazing eye-opener. I thank Dr. Urmila Anand ma'am, Dr. Manjusha ma'am, and Dr. Swarnalata ma'am for organizing this session. And I thank the audience for making this session a grand success. Thank you so much, ma'am, for sharing your